Lovely. So we thought at NRC Medical Experts that it would be good to have a webinar on navigating mental health services following brain injury. And in doing that, I'm joined on this panel by three colleagues who will introduce themselves later, covering the fields of law, general practice, oblique case management, oblique psychiatry training, that will all become patent later, and neurological rehabilitation and neuropsychiatry. We did have a colleague who was a neuropsychologist, but unfortunately she's unwell today and at short notice couldn't join us. So I think that's a shame. But if there are any people in attendance who are neuropsychologists or indeed clinical psychologists, I'd be very grateful if you could pitch in with your questions and or comments. And even if you wanted to join the panel at the late notice, then see whether you can dive in. Probably that won't be possible. Anyway, this is me, Edmund Bonikowski. I started NRC Medical Expert several years ago, and by background, I'm a consultant in rehab medicine, specialising in neurological rehabilitation. As we're all sort of getting our CVs out, I mean, I also trained as a GP and worked as a GP for a long time ago, and was a chartered engineer prior to medicine. So many things bringing myself to rehab medicine and quite a lot of commercial experience too. And so I think my feeling is this is a very important topic, and a few slides have been prepared just to introduce the topic in a very generic kind of way. So here are our panelists, Jemma, Koko and Rebecca. As I say, they're all going to have a couple of minutes later on prior to questions in order to introduce themselves. Next slide, thank you. So do please take part. This is intended not to be a lecture. It cannot be a lecture because it's not long enough. In any case, lectures are a bit dull and unstimulating. What we find is that if we get a good bevy of questions, then our experts and our panel can respond, and we can get dialogue between them as well as comments from them. So please throw your comments and or questions in. Now let me just move that over. There we are. So mental health and brain injury. Well, look, following brain injury, mental health changes are very common, and there are inordinate amount of research out there talking about the incidence and prevalence of various mental health disorders following brain injury. Let's just have a quick look, and it is just a quick look at some of the common themes. Sorry, I'm just having to fiddle over my, there we go. I've got all the panelists up there. Right, so what the research tells us, here we are, 4 very quick statements. The risk of developing post-traumatic stress disorder and major depressive disorders higher for people who sustain TBI. Now this is in itself, just very briefly, is interesting to me because I came from the school, which now appears to be old school and probably not correct, that if you had sustained a traumatic brain injury, then by definition, because you had not been conscious at the time, one could not have developed PTSD. However, that seems not to be right, and there's quite a large body of evidence now emerging that, particularly following mild traumatic brain injury, PTSD is a common sequelae. 1 in 5 individuals may experience the onset of mental health symptoms up to 6 months after mild TBI. In my clinical experience, I know that's a study. I think that's probably an underestimate. I would say that it's quite a lot more than that. I think it's a very, very common sequelae. People have been hospitalized for brain injury. So these are people who have sustained the more severe brain injuries, severe acquired brain injury and indeed moderate, are 65% higher risk from schizophrenia and 59% higher risk for depression. And those are just higher than the background population risk. So it's not saying, very obviously, it's not saying that 65% of people who have a severe brain injury become schizophrenic. But nevertheless, there appears to be, from some of the larger studies that have been conducted, a higher incidence. And following TBI, rates of depression and panic disorder was significantly higher than in the general population. And again, I think that's true. I would add anxiety disorder to that as a very common sequelae. Okay, next slide, please. Next, yes, there we are. Thank you. So I'm so sorry, I'm just having to move my toolbar of experts around so I can see the slides. Well, this is a fairly sort of self-evident statement. All cognitive, psychological, and emotional and behavioural skills come from the brain. Well, yes, indeed, they do. And existing mental health conditions can be made worse because of post-injury dysfunction in the way the brain communicates. Well, obviously, if you've disrupted pathways, then they are going to have an impact on one's prior mental health functioning. Psychological symptoms may be caused by direct damage to the brain. We know that. That's neuropsychological damage. And the impact of the trauma of the overall injury and the process of recovery can take a psychological toll. And this is really where we see post-traumatic stress disorder playing in, where we see anxiety disorders, adjustment disorders, and so forth. And let me just see if I can move that. Yeah, okay, next slide, please. So following brain injury, people might experience these problems, not all of which are mental health problems. I think this is one of the things it will be helpful to tease out here in our discussion. What is a primary cognitive problem? What is a behavioural problem? What is a mental health problem? Because it's too easy, I think, to throw them all into the same bucket and label them in that way. Whereas as we know, the diagnosis of mental health conditions is a very specific criteria-based process and requires real expertise. And indeed, the expertise of neuropsychiatrists who look at the more difficult aspects of mental health disorders and behavioural disorders post-brain injury is particularly apt here and also very rare. So just while I'm on that subject, I think I'm right in saying there are only about 50 neuropsychiatrists in the country, and I will put a substantial bet on the fact that there are not more than one, probably, people who have trained in rehabilitation medicine and also neuropsychiatry. And we're very, I think, privileged to have Koko Naing with us today, who has done both. So I think there's a real opportunity to ask Koko some searching questions about some of these diagnoses and the categorization of problems. Anyway, some of the problems following brain injury, we all know these: difficulty sleeping, depression, anxiety, PTSD, anger, frustration, and mood swings, cognitive problems, problems regulating behavior, and difficulty with family relationships. Okay, next slide, please. Mental health describes a wide range of psychiatric conditions. I know it says psychological there. I think these are three principal ones. I think there are a lot more. And navigating the diagnosis and services following brain injury can be even more complex by the overlap in symptoms. And that's why I think applying proper diagnostic criteria to the complexity of brain injury mental health is so very important, because it's a bit too easy to leave people who are struggling with primary mental health problems without the right kind of expertise to sort the wheat from the chaff for them. Okay, next one, please. Mental health post-TBI influenced by all of these factors: pre-injury personality traits, prior history of mental illness, well, that's for sure, history of alcohol and substance misuse, not only a history of, but of course, alcohol and substance misuse, which follows brain injury. It's influenced by the severity. That's certainly true for schizophrenia. Post-traumatic amnesia, ongoing cognitive impairments, tension, memory, and language. Well, it may be influenced by that. I mean, that's really about the severity of the injury and the functional impairments, which may then lead to stress factors, which lead to mental health problems. Obviously, damage to the frontal lobes of the brain associated with executive functioning, communication problems, and social factors. So a lot, as we know, a lot of factors which might precipitate a mental health problem. Thank you. So it's a complex journey. and individual clients, patients, whichever context we're in, their families, legal and case management teams face a long process in both identifying and accessing the right support. And I think it's important just to say again that identifying the right support is really predicated on making the right kind of diagnosis, and hence the involvement of psychiatrists, neuropsychiatrists, psychologists in post-brain injury management is so terribly important. Often physical symptoms of functional impacts are more visible problems, and they're addressed first, and that's certainly true. I think the other thing that's worth saying here is that it's a well-known correlate that physical disability and chronic illness are correlated with depression, very strongly correlated. So context crucial. Understanding the individual before their injury is key to establishing a way ahead, and hence good history taking is really important at every stage of the process. Okay, thank you. So here we are, here are our panelists. Koko, do you want to come in, please, and introduce yourself? Thank you very much.
Hello, yes, I'm Dr. Koko Naing. Yeah, unfortunately, trained in both neuro rehabilitation and neuropsychiatry. So yeah, over the years, I've been practicing both actually, because I was in the NHS for a short term and most of the time in the private sector. And then we ran both neuro rehab and neuropsychiatry at the same time. And then so I've been to run a neuropsychiatric service, you got to be the approved clinician like AC, and then responsible clinician RC, and then the section 12 to approved doctor. So I've been the RC, AC, and section 12 to approved for several years now. Yes, overall is you know, the brain injury come under the care of neuropsychiatric service in the UK. Practically, like in the third line, I said it is a practical difficulty is general psychiatry cannot or doesn't accept either you know brain injury patients with challenging behavior or the neuropsychiatric patients. So there is a little bit of division at the moment, and that's a reason that you know the patients are sort of missing the treatment in between because of not enough neuropsychiatric services in the country. That is, we all know that. So they were saying that only you know neuropsychiatric service based in the UK are only based in the you know limited number of the regional centers. You know you can have it like a Institute of Psychiatry, Morsley is a typical example. And then the waiting list is months and months. So there is a difficulty that the patients and the referrers are facing. As much as I understand from the Royal College and in the you know UK neuropsychiatric division is discussing about the you know what the future holds and how to develop the future service we provide. So as usual, we're asking for the funding sources, as everybody knows, and then the you know working together with commission. Yeah. So commissioning arrangements. I think my personal feeling is what are the you know service provision in details we should be able to provide to the commissioner, so that to be fair for the commissioner, they know exactly what they are purchasing. That is what we need to do for the each individual neuropsychiatric service, I think. And then we work together with all the branches of the neurosciences. As per brain injury, like you know everybody is experiencing, quite a lot of the referrals we have, like the common one, like case managers, solicitors, and then sometimes I come across like even individual cases as well, in the different form and shape. Quite a lot of stories in there actually. They are basically is quite a lot of people needs neuropsychiatric care, but they're still missing out. So yeah, we are going to listen to from the commissioner as well. So what, we are going to do, and then how much help we are going to get, and then how to improve the neuropsychiatric service in the country as a whole, NHS as well as in the private sector. That is all we hoping for. Yeah, thank you.
Great, thanks, Koko. That's super. And the next slide, please. Should be, there you are, Jemma.
Forgot I needed to unmute myself. Hi everybody, so I'm Jemma Morland. I'm a Solicitor Deputy in relation to property and financial affairs, and I primarily work on behalf of individuals who've recovered a substantial personal injury award, usually because they've suffered a traumatic brain injury, and I have then had several cases where clients have had that mixed presentation where they've also had mental health issues. So today I'm kind of bringing my experience, which is in kind of making sure that we look at funding options. It's obviously something I have to do as a deputy. I've got to work with the deputy standards, which is maximising income and claiming all statutory funding that's available. And then also as the person that's usually legally responsible for agreeing terms of business and appointing a case manager if one is involved, and then any kind of members of the clinical MDT, i.e. therapists that might be providing input and support to P. And then just about working with that MDT, establishing best interests, and then considering the interface between the Mental Health Act and the Mental Capacity Act. I'm not a Mental Health Act specialist, and I don't work in the arena of health and welfare. I have colleagues that do that, and they're much better than I at dealing with questions in that regard. But there is, there is a kind of interface between the two areas. It's very grey, as much as we're meant to kind of stay in our lane. They just are intrinsically linked, and so we find ourselves being pulled into kind of health and welfare issues, mental health issues. And we also have to be alive to whether someone has got a mental health problem presentation historically, sometimes before we've even become involved, because that's really important from a Section 117 aftercare funding perspective, and it's sometimes kind of underclaimed, and it's a really vital resource that you can tap into. So that's kind of the position that I'm kind of bringing to the panel today in relation to funding, management of finances, and claiming what we can claim.
Thanks very much. That's a very helpful introduction. Okay, and Rebecca.
Hello everyone, hi. My name is Rebecca Brady, as you can see from my slide there. I am a GP, practicing GP, also with a background in psychiatry, did several years of training in psychiatry before deciding to switch over to general practice. But I still maintain a high level of interest in the field. I'm mental health lead for my surgery, as well as just because of my background, I enjoy looking after patients with psychiatric problems and have a lot of experience of dealing with the complexity of their lives, really, not just their illness, but everything that goes around that. I'm also medical director of a company called HCML Rehabilitation Solutions. For those of you who don't know, we are a large case management company based throughout the UK. We have case managers who work in all areas of the UK, and effectively we provide case management solutions for patients who have suffered injuries which can be very catastrophic in all areas, including brain injury, through to much more minor stuff, but really size change, but I think from my perspective, really, as a GP, as medical director, everything should be holistic. We have to look at the patient as a whole. We can't separate one thing from another. And the problem is that in traditional psychiatric services nowadays, they have very, very strict criteria for who they can accept. And a lot of the time, and Koko has already said, services will not accept patients with TBI because they feel that they are far more complex than what the services that they can provide, and their services are already very overstretched. And also, I think one of the other challenges is, where does the traumatic brain injury and the coexistent psychiatric disorder, where does one start and the other end, really? When we are looking after patients in case management, the very first thing that we will do when we take on a case is do an initial needs assessment. And as part of that, a big focus is not just on the injury, the circumstances of the injury and the injury that's happened, but also on the pre-morbid functioning, what they were doing before in terms of vocation, pre-morbid conditions, both medical and psychiatric, what has been made worse, what has been made better, and what is kind of maintaining any of the problems. And again, like Dr. Bonikowski said earlier, it's always really easy to see the physical illnesses, and often we concentrate very much on the broken leg or the fractured pelvis, or, you know, amputations and things like that. But actually, in order to move forwards with anything, you need to really think about the psychological makeup of the person, what they want to achieve, their goals, and what's stopping them from achieving those goals. So I suppose, how do we successfully unpick this? That's the job of our very experienced case managers to do that, but we obviously use expertise from all sorts of different professionals in order to make those judgments, who give their own opinions, which form a bigger picture, and obviously our rehab consultants are one part of that. So yeah, very happy to answer questions on any of that, really, and but that's just a little bit of bit to start with.
Okay, so thank you very much, the three panelists, for introducing yourselves and comprehensively like that. I think we have a few questions which have arisen already. I can see we've got 54 participants on this webinar, and so far we have 9 questions. Kate, did you want to read some questions out, and then I can suggest who might have a shot at answering them?
Absolutely. So we've had a question here about if there's funding available specifically for mental health support as part of a settlement.
Okay, Jemma, why don't you come in and have a go at that one, please?
Yes, certainly. Obviously, I have to throw in the caveat that I am not a litigator, and so I cannot tell you whether there is a way for them to be able to recover damages within a settlement for mental health support specifically. However, in my experience, I certainly have seen it happen. I think it's all about the causative link, really, and what the litigator is able to evidence and demonstrate in the course of the proceedings. I know that there was the case of Martin v Salford in January of this year, which specifically talks about, kind of claiming for mental health support services within a civil claim. And it's a really interesting judgment. I definitely kind of would urge people to read it. It's well written, and it's comprehensive, decipherable. And the judge in that case did talk about the double recovery, and that's an issue that we as lawyers always have to think about. And express the view
that for us, for the non-legal people in the
audience.
Certainly. Double recovery, what's that?
So double recovery has been an issue that certainly as deputies we've been kind of facing for a few years, and it used to be we gave what was called Peter's undertakings due to the case of Peter's, where we've got to basically promise not to claim statutory funding if we've recovered an award of damages for a specific purpose that we're going to meet privately. And so we would give an undertaking so that basically you don't get 2 bites of cake. But more traditionally, and that was the very traditional view, but more recently the view seems to have changed, especially because there isn't any guarantee with regards to statutory support services, and there's also no guarantee that the award that you recover is actually going to meet all of your future needs. And so there does seem to have been a departation from that kind of mode of thought, which is good. That's how it should be, really. And so we are giving undertakings far less often, and are usually refusing to give them wherever possible. So and that really should be acting in peace best interests. So
that's very
I certainly have seen awards being recovered to provide mental health support services. It just depends on the link to the injury itself and on what you're pursuing damages for.
I think that's exactly right. I mean, just from my own medico legal experience over 20 years now, clearly one identifies mental health problems that appear to have arisen as a consequence of the brain injury. And I have found when trying to quantify the loss for the solicitors to litigate that opposition teams, defence and indeed judges, wherever it's been necessary, and that's almost never nowadays, are very open to this. As long as it is explained clearly why this has arisen and there's a credible argument to it linking in causation terms, then I think it is definitely recoverable.
Yeah.
Koko, did you want to have a word on that, Koko?
I think Koko just piping an answer to somebody else at the moment.
While we're waiting for Koko,
Yeah,
the only thing I would also add really is about what I'd kind of referenced before about statutory funding, which is even if you don't recover or do recover something within your claim of damages, I think it's always worth stressing that statutory funding, albeit it's clearly under a lot of pressure at the moment, is there and it ought to be applied for. And it's just making sure that people go down that route of us having a social care need or a healthcare need assessed. Yep. And making sure that you do maximise Section 117 funding if it's applicable. It's only applicable in certain circumstances, but once you've secured that funding is technically provided for life. If a need arises, even if that need does kind of ebb and flow during the course of your mental health diagnoses. So it's also about making sure people do claim what they can, what they're entitled to.
So if it's part of the claim, it's part of the claim, as long as you can substantiate it with some expert evidence.
Yeah, and if it isn't, then try and get what you can through statutory services, really.
Absolutely, yeah, absolutely. Koko, are you free to respond, or are you just tied up doing something? Rebecca, do you want to come in on that? Yes, please.
Can I just add from I suppose from the in the context of case management, I mean, obviously, we will do the initial assessment, and then we will work out what the goals of the client is, and also the needs of the client, and they will be both short-term and long-term. But as part of that, we can secure funding from the insurers, from the solicitors, in order to basically put into place whatever services we feel are appropriate. That is the job of the case managers, in order to decide what services need to be accessed, what experts need to be involved, and potentially packages of care, or developing, approaching different services. So that is also something that we get heavily involved in during the process of the claim. And obviously one of the things that we can come up against sometimes is that I suppose traumatic brain injury can lead to things like lack of motivation. It can lead to lots of other psychiatric issues as well as the kind of comorbid PTSD. Or I've got one case at the moment that we were discussing this morning where someone was run over by a car that was driven by someone else that he knew, and he's got extensive levels of paranoia now about actually going out the house and being struck by a car again. But then at the same time, if he's being taken to appointments and things, you've got to think about mitigating risks as well, and just making sure that you are playing your part in the rehab. But it makes it very difficult when there's a TBI involved, as to how much they can do and how much they're able to do themselves.
Yeah, and importantly, just picking up on that, I think where case managers are involved in commissioning services, they do need to ensure that they've got the right kind of diagnosticians making the judgments as to what the clinical problem is. I think where there's a weakness in the case management world, and I was heavily involved in that myself from 2001 to 2010, is for case managers to take that monkey on their backs themselves and sometimes not get it right. And I think that's a potential tragedy for patients. I think insurers have historically seen case management as a nice, useful tool for articulating with a case, and are perhaps reluctant to release as much funding as sometimes the cases would merit. So I think there's a real tension in case management at the moment, but I would certainly advocate the use of mental health professionals and neuropsychologists and neuropsychiatrists, where you can get one, and you won't be able to complement the approach of the case manager. I think the idea that rehabilitation and case management are the same thing is clearly wrong, and we do need to be very careful about that. Okay.
Yeah, I think we support the coordination of the process really through the rehabilitation. That's our job.
Absolutely, thank you.
We've had an interesting question. Yeah, an interesting question that might go to this. So when my clients are undergoing assessment, if a neuroconsultant visits them, do they look for mental health conditions too, or do they need another expert opinion from a psychologist or a psychiatrist?
Sorry, can you read that again? Somebody's got if the other panel experts could please mute, that would be helpful. Kate, could you just read that again?
Yeah, so when my clients are undergoing assessment, if a neuroconsultant comes to see them, do they look for mental health conditions too, or do they need another expert opinion from a psychologist or a psychiatrist?
Okay. Well, let me dive in on that one. I mean, any competent neurorehabilitation physician should be capable of making the common mental health diagnoses without reference to a psychiatrist. When the diagnoses are more refined, then referral, behaviourally related, then referral to a neuropsychiatrist is really important. Equally, when the primary psychiatric diagnosis is complex, then of course a referral to a psychiatrist is helpful. But it's a question of the extent of the problem, from my own experience, as to whether one needs to call in additional expertise.
From my perspective, just thinking of the question, I think it's really important to actually make the distinction between general neurologist, which is I think what the actual question was asking, rather than neuro rehab consultant, because I think there is very much a difference between the two.
Of course there is, yeah, absolutely. And if I've misunderstood the question, I apologise.
Yeah, and I would say neurologist. I would say most neurologists probably would steer well away from psychiatric problems, and actually in that case you would need a psychiatric opinion from them, most general neurologists that I know anyway, whereas I would expect that most neuro rehab consultants would have very much more of a holistic view and holistic approach to it. But yeah, straightforward neurologist is not sufficient for psychiatric diagnosis above things that they would have learned back in medical school or psychiatric jobs that they may have done.
Yeah, I think neurology, if I've misunderstood the question, I apologise to the questioner, but I think that's absolutely right, Rebecca, that neurology is a very particular medical discipline that has application, obviously, medico-legally and in terms of diagnosing some of the complications of brain injury. But actually bringing a neurologist in to diagnose whether there has been a brain injury is often superfluous, really, because the neuro rehab physicians are more than capable by virtue of experience of doing that. And in fact, I think it's important to just flag something there, that only about 5% of all people who have a brain injury are ever seen by a neurologist, whereas a much higher percentage are seen by neuro rehab physicians. And indeed, when you talk about spinal cord injury, it's about 2%. So the idea that the medico-legal legal world turns to neurology as its first port of call, I think is fundamentally flawed. I would advocate, if you want to understand what has happened to a patient and what their functional impact, both physically and cognitively, on that patient is, then neurorehabilitation is a very good place to start, and then rely on your neuro rehab expert to call in and suggest neurology if there's a particular problem, complex epilepsy, for example, so forth, and then to call in neuropsychiatry or indeed general psychiatry, depending on the array of problems that present, for a more detailed, focused analysis. I hope that gives some kind of answer to the question. Kate, have we got another one, please?
Yes. Are you a priority for mental health support if you've suffered a brain injury?
Are you a priority for mental health support? Well, in my experience, no.
No.
But I'd be very interested to hear what Rebecca thinks about that from your past experience. You're a functioning GP at the moment. I know you in part time. You're with HCML, but you're a practicing GP at the moment in the forefront. You will be seeing patients who have experienced at least mild brain injury rolling up in your clinics occasionally. Are they a priority for their mental health problems?
No, but they should be. But I think that's partly because there's not the services available.
Yep.
And I think a lot of it is too complex for a lot of GPs to be able to have the time to deal with, unfortunately,
Yes.
and B, actually the expertise, and a lot of the time, because of the symptoms that people present with, they're often pretty chaotic sometimes. Lack of motivation, they won't attend appointments. So and it's not their fault, but it's just the way things are. So it can be very complex. I personally find it very interesting, and I just kind of take the same approach as I would with anybody, in just taking kind of a holistic goals-based approach, really, because I think sometimes that's the only way you can do it,
Yes.
and try very, very hard for them to get into psychiatric services. But unless they're presenting in a crisis, I think a lot of people are finding it very difficult to access psychiatric services anyway, at the moment, whatever their condition, and the brain injury just adds an extra complexity to that. I would just add to the last question as well. You're more likely to see a neurosurgeon, and neurosurgeons are absolutely brilliant. So, you know, evacuation of hematomas. So for the person asking the question, evacuation of hematomas, you know, repairing spines, nerves, all sorts of things, you know, you're very much more likely to see a neurosurgeon, and they're brilliant with the Meccano side of things, and putting people back together again. But then they kind of then has to, you know, then go into the rehab side of things, and then onwards, which is what we tend to see commonly.
Well, what they do, Rebecca, the neurosurgeons are very good, as you say, brilliant at the technical stuff. And when that's done, they go, done.
Yeah.
And those patients just get discharged if they can be discharged, or passed on to rehab. And then you get the sequelae of the problems picked up by the holistic services that are neurological rehabilitation. That's absolutely right. And so I think in conclusion, it is the case that no, just because you've had a brain injury and you then have mental health sequelae to that, you are not a priority elevated above other people who have a primary mental health problem. And Rebecca's right. Of course, that would be, in an ideal world, you should be. But we don't live in an ideal world. We live in a funded limitation world, and limited world, and that is the stark and harsh reality. Of course, in you know, we are all talking in the context here of medico-legal and litigation, case management, and so forth. That does afford, in the case where, you know, there is an appropriate claim to be made, that does afford people an advantage of seeking private support for mental health problems. But even that can be difficult to ascertain, to access rather. And of course, as Rebecca's absolutely right, that if you have mental health problems, then it, you know, if you had a brain injury, can affect your motivation, can affect your compliance with treatment programs. You might have spun off into drug and alcohol abuse, and it makes the management of your primary mental health problem, either sequelae to brain injury or beforehand, that much more difficult. This is a really phenomenally complex area. Koko, did you want to comment?
Sorry, what's that?
Did you want to comment, Koko?
No. It's like, you know, earlier on, I don't know whether I got through or not. I was talking earlier on. Yes, the accessing to the neuropsychiatric service, yeah, it's people find it difficult. I noticed that nowadays, like Dr. Brady said, a neurosurgeon is a more accessible sort of thing. So yeah, that is a thing. My experience as well, actually. Yeah, probably neuro rehab might be the similar thing, actually. Yeah.
Yeah, I'd say in the NHS, when I'm still sort of clinical director down in Somerset of neuro rehab, accessing neuropsychiatry is almost impossible. It really is extraordinarily difficult. Your patients have to be in extremis on the ward before you can get a psychiatrist, neuropsychiatrist, to come and help with the management of complex post-brain injury behavioural problems. It's not a criticism of them. It's simply a question of the fact that there are only about 50 in the country, and they are, as Koko said earlier, concentrated in regional units like in Bristol, for example. And of course, the neuropsychiatrists are often dealing with functional neurological disorders and so forth. So the brain injury is only a little bit of what they do. So, you know, we really do face an enormous challenge accessing the right kind of mental health services for our brain injury patients. And therefore, I think it behoves all of us who are specialists in other disciplines or generalists, you know, generalist therapists or nurses or anybody, to equip ourselves with enough understanding of the basic mental health disorders so that we can identify them and at least signpost people appropriately and not miss more straightforward diagnoses, which I think does happen. Okay, Kate, another question if we have one.
Sure. So someone's mentioned that in the initial slide there was a statistic that people develop mental health issues up to 6 months post-injury. So they've asked how we would go about accessing mental health services at a later date rather than in the acute phase after an injury.
Okay, Rebecca, do you want to do that one? Have a go at that? How would you go about accessing them? I mean, this are we talking here, is the question, well, we don't know, but is the questioner talking about the medico-legal context, or are they talking about in general terms? I think, because I think there's a real dichotomy here in society between those people who sustain a brain injury where there is a compensation claim that can be pursued, and therefore they're likely to get significantly augmented services, and those who don't, who are likely to do, sadly, relatively poorly in terms of service access. Rebecca, do you want to comment or give an answer?
I think you've hit the nail on the head really there in terms of it depends on whether it is found, because a lot of the time we will take on clients several months after they've had their initial injury because either they've been in hospital or the case has just been taken out to something. For solicitor and legal representation, I would say that it will be very variable throughout the country as well geographically as to what services you will be able to access depending on what area you're in. And obviously if you're in the case management space and you're being looked after by somebody, then you have a wide range of NHS and private services, and I think it does come down really to the commissioning of services in different areas and what they will accept as their criteria. And the NHS ones are generally very.
These patients face a double whammy, don't they? Who've had brain injury and mental health problems, because you know neurological rehabilitation services are extremely sparse and poorly funded, and mental health services similarly. And actually, if you've got both, then your chance of getting all you need from both services is vanishingly small, I'm sad to say, in my experience, certainly in the NHS, in the public sector. I think it's very different, again, as Rebecca's just agreed with me, that you know where there's a litigated case, where there's funding and a settlement, then it's much better, but it's by no means guaranteed then, because it's still very tricky to navigate what people need.
I mean, what I would say is that I think in general practice, we're trying really, really hard to we've recently the restructuring of the general practice space with PCNs, so networks of practices working together with allied members of teams. I mean, I work in a PCN where we have great resources from social prescribers, from mental health OTs, and we commission them as a group of practices. So they work throughout the surgeries, and actually it's great because I can have somebody that doesn't necessarily need my medical supervision every week, but I can pass them on to my colleague who can, you know, talk them through, you know, vocational rehabilitation and supporting them with their anxiety and giving them practical things to do. So I think where we are, we're really lucky that we've got that service kind of in place because we've identified it for our group of patients. So, you know, I think we are trying, but I think it's just it's just a fact that there's a lot of lack of unjoined up working, a lot of working in silos in the NHS, and that needs to change as far as I'm concerned.
We're all struggling to try and make that better. Jemma, did you want to comment from your experience?
I mean, in my experience, I think actually mental health services do tend to be accessed, you know, in that post-acute phase. I think, you know, usually that acute phase is focusing on people getting better from their physical injuries, as Rebecca had kind of referenced before, you know, focusing on the broken bones and everything else. And so, yeah, but I have to say, I mean, we're mainly kind of involved in accessing private services, but even our wait for a private neuropsychiatrist is several months just for an initial assessment, and that's when we're paying someone £595 an hour for an assessment. So I think you're right. I think they're scarce, and more people need to qualify into the field.
They do. Okay, thank you for that. Kate, another question.
So we've had a
I can
couple
see
of...
Dr. High, by the way, I can see Dr. High has made a comment.
He has.
That doesn't look like a question, but the comment is, one of the main issues is that a person with a head injury and their support network are not routinely given information on how to access mental health services. Navigating the information pathway is a real challenge for many people. I think, I mean, I work with Dr. High actually, so I agree with him absolutely on that. And thank you, Inam, for making that point. Kate. Yeah,
we've had a couple of legal questions for Jemma, so I'll read them both. So as a solicitor managing affairs for people that have suffered a brain injury, the first question is, do you find that there's enough funds to meet their needs? And also, when people are going through the legal process, does this impact on their mental health in itself?
Yeah, no, absolutely. In terms of impacting on people's mental health, it's a bit generic, but my answer would be yes. I absolutely think that it's a hugely traumatic thing for people to have to go through. The uncertainty is the biggest issue. I think uncertainty for any of us in our day-to-day lives is the thing that causes us, you know, the biggest complaint. And I think when you've got this complex litigation, which may or may not be worth nothing up to several £1 million, and it's the, you know, the difference between having a future that might provide you with a quality of life and not, is massive. And so I do see I see various reactions actually post conclusion, and so I suppose that's where I'm kind of in a slightly different position to litigators, is that we kind of see the aftermath of a settlement. Is that some people just see it as a huge relief, and you know, and that can actually be a kind of solve all issue, and they're able to move forwards constructively. And for other people, it's a bit of a self-destruct button, and we can see things, you know, actually decline. So yes, I think, you know, in my experience, a complex litigation claim can definitely impact on someone's mental health, and that can either be positively or negatively. But you know, usually it can be quite tricky.
I completely, by the way, I can completely concur with that from my experience over 30 years. That litigation is pernicious, and you know, it creates such uncertainty and also such demands on the client, on the patient, for being assessed and for performing and or not performing, because of course, if you know, I mean, the claimant lawyers in the audience will probably shoot me for saying this, but you know, it is potentially perceived as an advantage not to be recovering, not to be performing. I mean, it's actually, that's not true, but some clients see it that way, and some solicitors who are not experienced in this area, you know, some high street solicitors do unfortunately get involved in these complex cases, and you see the most almighty misinstruction of clients, you know, with regard to recovery and functional improvement, and the clients get confused. And when they get, you know, an assessment by the claimant and defendant neuro rehab expert, a neurologist, a neuropsychologist, OTs, care, all of a sudden, and these will go on and on and on for several years. In my experience, definitely for 3, 4, 5 years on severe traumatic brain injury cases, that's exhausting for patients, exhausting. And
there's a time when
stress precipitates mental health problems.
Sorry, and it's at a time when a lot of people are also under immense financial pressure. You know, they're often not earning money. You know, their family are having to provide support and care, give up their own kind of career aspirations, caregiving responsibilities. It's massive. You know, it's hugely stressful.
Changes of role as well is very
very
important.
And that dynamic between, you know, them and their loved ones. And I think actually, if that's anything that we can learn throughout that process, is that collaborative working between opposing counsel and, you know, working via the rehab code, the use of interim funding, just to relieve some of those pressures, I actually think you'll get better outcomes.
I agree with that entirely. Sorry, were there 2 questions there, Kate?
Yeah, there was another one about the funds and kind of longevity. I mean, that's a bit of a finger in the air because it is quite generic, but I mean, and by and large, I would say that that's probably the success of the deputy is how you're able to manage those awards. You know, our job is to try and maximise the funds and to ensure that they last until they take their last breath. So
yes,
we are always looking at life expectancy. We're looking at annual expenditure and our income, you know, requirements and what's affordable and what's proportionate, whilst also balancing P's best interests and their wishes and feelings. And you know, sometimes it is about saying to them, well, if you spend this much, it will result in your award, you know, lasting a lot less and running out when you're this age. How do you feel about that? And for me, I'm all about maximising autonomy. I think all of the experts on the panel would agree. You know, it's really about us enabling and empowering our clients to, you know, to live the life they want to live, but putting in those protective constraints where necessary. So I find that the funds last as long as they need to, you know, and that's often, you know, factoring in a lot of different things. But, you know, I haven't had major issues. The biggest problem is compromised awards, that they are tricky because you actually have somebody that's got high needs, but without a private award to meet those needs. And then you're not always able to acquire what you need via statutory routes, which is a shame.
Thank you. Thank you very much for that. I think we're getting to, we've got four minutes left. Kate, have we got another couple of quick questions that we might throw in?
We have a question. My son had a brain injury and his anxiety is very high, more so than ever before. Who do I get advice from, my GP or the case manager?
Okay, we've got a GP who is representing a case management company, so let's let her answer that. Slam dunk there, go for it.
Yeah, so I mean, if you've got a case,
by the way.
yeah, if you've got a case, I mean, if you've got a case manager involved, then obviously it would be their job to liaise with the GP if they're able, if they are liaising with the GP, and often they will do, to see what has been done already, and what services can be accessed. Again, for a child or for anybody, you know, there are lots and lots of services out there to support with anxiety, both, you know, psychological services, medication services at very different levels. So really it very much depends, but I would suggest, if there's a case manager involved, get the case manager to kind of liaise with the GP first, and if not, then perhaps with a psychologist or a psychiatrist if required. At that point,
or both, Jemma. Sorry, Rebecca. Both. So if you are a patient with these problems, just because you have a case manager doesn't mean to say you have to have a case manager has to act for you. Yes, they may be able to contribute something very helpful and influence and so forth, but actually you are the patient of the general practitioner, and you should be able to go to that GP and say, "This is my problem." So I think a twin track approach would probably work best, wouldn't it? Yeah,
absolutely.
Okay, final question. Then let me just look. Who do I turn to? I think I had a stroke 10 years ago that was misdiagnosed as schizophrenia. No psychiatrist refer me to a neuropsychiatrist or neurologist. Well, I think the truth here is if the person asking the question thinks that they have suffered a clinical negligence, then they should approach a clinical negligence specialist solicitor and present the facts, and then that solicitor can consider whether there potentially is a claim there, and if there is, they can then orchestrate the appropriate expertise to assess the situation. I think it's probably very difficult to comment further than that, but you know, definitely, I think if individual patients feel they have been misserved one way or another, then it is my experience that the health service is generally quite poor at righting the wrong and signposting people to the right services. So I suggest contacting a reputable clinical negligence firm and discussing it with them. So I'm not going to ask any of the other panelists to comment on that because we're out of time, and I hope that was a useful comment. Okay, Kate, are we? I think we are out of time now, aren't we?
Yeah, we are. So I'll let you close. Just to say, I'll be sending the recording transcript and an audio recording so you can listen to the podcast as well to everybody who was registered after the event.
Okay, well, first of all, my thanks to the audience, all 50, I think 58 of you at the peak, which declined us slightly towards the end. Thank you very much for taking the time to join us on this webinar. I hope you found some of our comments helpful. There are always more questions than answers. This is a very complex area, and we hope that we can revisit it again. And also my thanks to our panelists who I think have risen to the challenge of remote communication extremely well, and have provided some genuinely helpful insights. So thank you to the three of you. And Kate, thank you for organising this on behalf of NRC medical experts. So with that, I'll close. And if anybody wants to send in more questions, then please email us, and we'll do our best to respond individually. So thank you very much, and good evening.